Okay, welcome everyone. I'm Leah Al-Korh. I'm the lead coordinator at the International and Global Health Office at the University of Ottawa. And I would like to welcome you all to the third Global Health Learning Network event for this academic year, 2023-2024. Please note that the session will be recorded. Before we begin, we pay respect to the Algonquin people, who are the traditional guardians of this land. We acknowledge their long-standing relationship with this territory, which remains unceded. We pay respect to all Indigenous people in this region from all nations across Canada who call Ottawa home. We acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future. The Global Health Learning Network is a series between the School of Epidemiology and Public Health, the Bruyère Research Institute, and the WHO Collaborating Center for Knowledge Translation and Health Technology Assessment in Health Equity and the International and Global Health Office, IGO. This event is an accredited group learning activity, Section 1, as defined by the Maintenance of Certification Program of the Royal College of Physicians and Surgeons of Canada and approved by the University of Ottawa's Office of Continuing Professional Development. You may claim a maximum of 3 hours. Credits are automatically calculated. This 1 credit per hour group learning program meets the certification criteria of the College of Family Physicians of Canada and has been certified by the University of Ottawa's Office of Continuing Professional Development for up to 3 main Pro Plus credits. The learning objectives for this sessions are to understand the multifaceted challenges in global health through the lens of UOttawa students, including insights into infectious diseases, social accountability, and the role of health workers, analyze the practical implications of global health initiatives as shared by the University of Ottawa students, evaluating their strategies, successes, and lessons learned in addressing health disparities and promoting equity across borders, explore personal and professional growth opportunities in global health engagement, drawing inspiration from the diverse experiences and perspectives of UOttawa students, and identifying potential avenues for future involvement and impact. It gives me great pleasure today to welcome our speakers, Ms. Amarachi Asamuga, Mr. James Sakia, Mr. Musa Sangare, and Mr. Charles Thixton. I'd also like to welcome our moderator for today, Claudia Duguay. Claudia is a PhD candidate in epidemiology at the University of Ottawa and holds an MPH in epidemiology also from Drexel University. She's the Global Health and Social Accountability Ambassador and will be the moderator for this session. Claudia's areas of interest and expertise include the control of neglected tropical diseases using a One Health approach. Over to you, Claudia.
Thank you. So as Leah mentioned, we have 4 great speakers on the agenda today. So we have James, Charles, Musa, and Amarachi. So each speaker will have 10 minutes to share their work and experience, and then we'll keep all of the questions for the end of the program. And so we just ask that you put all your questions in the chat, and then hopefully we'll get to all of them at the end of the program. And with that, I'd like to present our first speaker, James. And he, oops, sorry about that. We went a little too far there. So James is a PhD candidate in epidemiology at the University of Ottawa, and he holds a Master in Science and Health Sciences from the University of Lethbridge in Alberta. And he will share his experience exploring the meaning of resilience and well-being among community health workers in Ghana. So off to you, James.
Thank you very much, Claudia. I will be presenting on my, is it active? Can you grant me? Still can't control my slides. So thanks once again. My name is James. I'm presenting on my PhD dissertation, which is longitudinal investigation of resilience and well-being among community health workers in Ghana, the influence of seasonal variations. So basically, the presentation will go along this way. I'll just provide an overview of two of my projects. And then when time permits, I'll add important considerations for global health research at the question and answer period. So community health workers are very critical and pivotal to the public health in low and middle income countries. However, they face challenges like lack of resources, lack of workload guidance, and seasonal stresses like heavy rains and agricultural activities. So we do have an attrition rate, and some programs have reported attrition rates of 35 to 40% from community health workers. And many of these factors that affect them within their social ecology. However, there is limited information on resilience of community health workers, and the current cross-sectional and quantitative studies do not capture the full range of contextual specific factors that shape resilience and well-being. Resilience and well-being are a dynamic process and amenable to the context. So the purpose of my PhD is to investigate resilience and well-being of community health workers in Ghana across time. This is grounded in social ecological perspectives where resilience and well-being are determined by dynamic interactions of factors at individual, relationship, community, and societal level. So my dissertation is kind of organized in three chapters. The first is a scoping review, the second is a qualitative study, and the third is a cohort study. Now for the qualitative, we'll ignore the scoping review as it has a lot of components that there's no time to discuss. But for the qualitative study, my first attempt was to explore the meaning of resilience and well-being in Ghana among community health workers. So while it is important to look at resilience and well-being of community health workers, research approaches, like I said, are predominantly quantitative. They are limited in their ability to capture the full range of context-specific factors. Resilience is not simply an individual trait, but it is influenced by the person's environment. And in the African context, perceptions of resilience is influenced by culture and everyday experiences. So this particular arm of the study kind of like adopts a qualitative approach to explore the concepts of resilience and well-being. This will help us gain insights into the cultural and social context that shapes these constructs and the mechanisms by which they are formed and maintained. So the broad objective is to explore resilience and well-being among community health workers and their underlying social ecological processes and interactions in Ghana. The aim is to understand the meaning of resilience and well-being and identify contextual processes that influence resilience and well-being within their social ecology in Ghana. So we adopted a phenomenological approach. This is to understand the lived experiences and collective understanding of resilience and well-being. We conducted 20 in-depth interviews, 16 of whom were CHWs and 4 stakeholders. And then our analytical approach was interpretative phenomenological analysis, which first explores details of participants' personal and social worlds. It also requires interpretation, which is hermeneutics and an active role of the researcher. So this requires multiple readings of your interview transcripts, and then seeking some relationships within those transcripts and clustering these relationships into teams. The results show that aspects of resilience emerge as expressions of reciprocal altruism, personal agency and drive, community solidarity, and sentiments tied to religion and spirituality amidst adversity. So resilience is shaped by, in other words, social ecological factors that kind of shape resilience are individual strengths, those are emotional strengths, community perceptions or relationships, the resources available to CHWs, beliefs, that is religion and culture, and most importantly, the seasonal challenges. So based on the seasonal challenges, this leads us to my second study, which is an examination of the seasonal resilience and their impacts on well-being of community health workers in Ghana. Now, resilience and well-being are not single events, they are dynamic processes. However, current understandings, like I said earlier, are cross-sectional. These are not fully representative of the complex ecology of resilience as it evolves over time. Also, the relationship between resilience and well-being has not really, especially among community health workers, has not really been thoroughly examined. Seasonal variations present significant challenges in healthcare in tropical and even subtropical regions. There are disparities between dry and wet seasons. For instance, wet seasons, there is high morbidity and mortality, stretch healthcare resources, activities such as farming. The dry seasons, on the other hand, low morbidity and mortality, healthcare access is usually good, and there is steady healthcare provider availability. These variations can alter daily routines and priorities, as well as introduce potential stresses. Given this contrast and implications, it is important to examine how these seasonal variations affect resilience and how this impacts on CHW well-being as well. Now, the study will be in the Upper East region of Ghana, which is in the northeastern part of Ghana, bordered by Burkina Faso to the north and Togo to the east, and then the northern and upper west regions. The climate is tropical, continental, and interior savanna. We have a single rainy season, and then a prolonged dry season characterized by dry harmattan winds, reduced humidity, and cooler nighttime temperatures. So temperatures fluctuate between 15 and 45 degrees, depending on the time of the year. And then we identify a transitional month, which is usually between September and November, where most of it is not too hot or too cold, and it is also the harvest season. So the broad objective is to investigate resilience during Ghana's three climatic seasons and explore the linkages with well-being. So specifically, how seasonal changes, particularly the rainy season, influences resilience and well-being, to determine the linkage between resilience and well-being across the dry, rainy, and transitional seasons, and examine the possible reciprocal relationship between resilience and well-being. Now, our primary hypotheses are community health workers' resilience and well-being in Ghana will vary across different seasons, displaying lowest level during the rainy season. And there will be a positive reciprocal relationship between resilience and well-being. Now, we also examine some effect modifiers like gender, campaign types, and also examine the contribution of each of the Resilience Research Center or resilience scale. This scale has three components: individual relationships and context to overall resilience, how these sub-scales contribute to resilience. So it will be a core study, 3 districts and time points, dry, rainy, and transitional seasons. CHWs will be selected based on whether they are currently active or have access to telephones. And then the sample size will be 450. We'll examine demographic factors, and then we use the Resilience Research Center Adult Resilience Scale and the WHO 5 well-being skills. Now, these are some considerations for global health students and maybe practitioners. If there's time, I'll go in detail, but I want to talk on costs and funding, ethics, building and leveraging local relationships, and cultural sensitivity and self-awareness when you go into the field. The study was funded by IGO and then Bruyere Research Institute. And thank you for your audience. If there's time, we will talk about the considerations that I mentioned earlier.
you so much, James. I also hope that we have time to discuss those considerations at the end. And a reminder for all the attendees that if you have any questions or comments for James, just put that in the chat and hopefully we'll have time to address them at the end of the program. And now I'd like to introduce our second speaker, Charles Thixton. And Charles is also a PhD candidate in epidemiology at the University of Ottawa, and he holds a master's in science in epidemiology also from the University of Ottawa. And he will share his research on the acceptability of treatments to inform social mobilization campaigns in Papua New Guinea. Off to you, Charles.
All right, thank you so much. Okay, there we go. Okay. So so I'm going to talk today a little bit about the acceptability of mass drug administration for lymphatic filariasis in Papua New Guinea and some time that I was able to spend in the field there. There we go. Okay, so to start off, lymphatic filariasis is a parasitic infection caused by 3 filarial worms. It's vector-borne by a large variety of mosquito species, but specifically Anopheles in the context that I'm going to be talking about. And these worms enter your lymph nodes and cause a swelling called lymphedema, which over time can be debilitating and cause major disability. You may have heard it called elephantiasis before. These worms can live for up to 6 to 8 years in a person, and they can be asymptomatic for most of the time that you have them. So they can be building and causing damage without any external symptoms or knowledge of the patient who has the condition. So in order to treat lymphatic filariasis, we have several drugs that are very effective at killing the microfilariae, or the baby worms inside your body, especially when taken together. And it's much more effective to treat an entire population at the same time, because this reduces the level of filarial worms in the general population. And because it's vector-borne, if mosquitoes don't have any microfilariae to pick up, they can't transmit them to other people. Historically, we would need to treat someone once a year up to 8 times, so up to 8 years of mass drug administration, although we have some new information that may change that. But in general, we say that if we can reach 65% of a population at random each year, we can bring the transmission levels below a level that they can continue. So the microfilariae will die out and there will end transmission. So that brings us to acceptability. So acceptability is a measure that we use to determine whether someone would be willing to participate in an intervention that we give. In general, we say an acceptable intervention must be important to the people that it's servicing. It must be appropriate to the context that it's used in, and it must be effective at treating the condition or problem that we're dealing with. And we measure acceptability by asking respondents a set of questions to determine a score. So each question asks the respondent how much they agree with a statement. So for instance, these drugs work against lymphatic filariasis. We ask them if they agree or disagree. And then if they say that they agree, we then ask if they strongly agree or just agree, and the same thing for disagree and strongly disagree. Once they've responded to all 9 questions, we have a total acceptability score that falls and covers all 3 of the categories we described earlier in some nuance. And then these are translated into a numerical score, which is then summed to create their acceptability score. And we use this score because interventions lose their impact in systems. So if you have an intervention that's 90% effective and you don't have a way for patients to access it, it's too expensive, providers don't distribute the treatment, people don't take the treatment once they have it, you suddenly are left with an intervention that's much less effective than when you first started. And so we can improve each of these points. So we can create better and more efficacious drugs, which we've done. We have the most effective, the drugs that we have for lymphatic filariasis are some of the best in the world. We can provide them for free, which we have agreements with major drug production companies that they're providing these drugs for free in perpetuity until LF is removed as a public health problem. We can fund mass drug administration. We have governments and the World Health Organization that are all on board with providing funding to ensure that people have access to the drugs and that we can deliver for them. And lastly, we have to convince people to take them. And that's where this comes in. So in East New Britain province in Papua New Guinea, we conducted a series of acceptability studies around a mass drug administration campaign. So over 3 years, we had multiple components. We started with community-based cluster surveys at baseline, endline, and follow-up, and that's mostly what I'll be talking about today. We also did qualitative research on preferences of acceptability in public health campaigns with focus group discussions, key informant interviews, etc. And then importantly, throughout all this process, we communicated our results back to the East New Britain Public Health Authority to ensure that they were able to action on these data points that we were collecting. So I was lucky enough to be able to travel to Papua New Guinea twice during this time period to train 2 exceptional field teams and teach them how to ask the questionnaire, deliver the REDCap data back into our servers, and engage the community directly. In our first baseline survey, we didn't have any data on acceptability yet because we hadn't run an intervention. So we couldn't ask people how they felt about it. So most of our baseline surveys focused around questions like, where do you get your public health information? What would you like us to deliver this information to you as? And as you can see here, health workers, community village health workers play an enormous part in Papua New Guinea in delivering health information. And they do so mostly through radio and what they call talk sabes in Papua New Guinea, which are sort of community meetings and gatherings. And so anytime that you do anything in Papua New Guinea, you start with a talk sabe. So you engage the community directly, you deliver information about what you're going to be doing, and they ask questions back to you, and it creates a dialogue at every step of the way so that you can have this engagement process. And this is just baked into the culture in Papua New Guinea. This is how they deliver any information about community projects. And so it's really, really convenient to be able to go in and communicate all this information in that way. We also identified important messages from the baseline survey, focus group discussion, and key informant interviews. Some of the brief ones here that we decided were really important to focus in on before the first survey. Who's eligible for the medication, what medication is going to be handed out and how it works, why it's important to participate, where and when the distributions will be happening, and then how will the distributions happen? So like, what is the process that will go on when they arrive? And all of these things are really important just in general for campaigns to make sure that people feel comfortable and interested in participating in an intervention. These are all questions that people will have, and they're all questions that we have the answers to. So there's no reason not to communicate them to the population. After our initial survey, after our initial master administration, we were able to go back in and do a follow-up, although it was somewhat interrupted by COVID, but that tends to happen. And this is our range of acceptability scores from after the first round of MDA. As you can see, we have a very high distribution of acceptability scores. People were very, very pleased with this intervention and excited to join, but we're still able to assess some information from this distribution and see where some of the people who are maybe less accepting might have had commonalities. So in particular, with our regression model, we were able to show that men were slightly more accepting than women. We were able to show that level of education was associated with acceptability. Those who had a high self-rated understanding of LF were more accepting. So if you felt that you knew a lot about it, if you understood that the worms are what cause lymphatic filariasis, you were much higher acceptability than if you didn't, which is good because we can communicate these kinds of information. And then we had this flag, this is a red flag, that drug safety and adverse events were important concerns. So people were concerned that these drugs weren't going to be safe for them to take. We tend to see this sometimes because if you have a high worm burden and you take the drug, the next 24 hours can feel pretty debilitating because your body's clearing out all the worms. If you don't have any worms in your body, you take the drugs and you feel pretty much the same the next day. So it does have this small amount of, like, especially after early rounds, we want to be a little concerned about any drug safety and adverse events questions. So we were able to communicate all this information back to TNG-IMR and to the Public Health Authority and move into the social mobilization process for the next round of MDA with these points in mind. So can we target women in some meaningful way with social mobilization? Can we send out more messages about what lymphatic filariasis is? Can we talk about the safety of the drugs? And those messages go through the social mobilization campaign, and then we run another MDA with another round of drugs, and we come in again, and this time we assess the same variable questions to see if the same messages are still moving. There we go. So in our second follow-up, we had a slightly lower distribution of acceptability scores. This tends to be normal because as people become less and less excited about a new campaign, they fall off a little bit. You may see this with like COVID vaccinations. Everyone was really excited to get their first 2 COVID vaccines. The third one, a little less so. The fourth one, the fifth one, I don't know. People can even remember when their last COVID shot was, but we've sort of, it's left our public consciousness. And that's the same thing that we start to see. So we really want to keep scores as high as possible, but we do need to work fast while we do that. And again, we're able to pull out some really interesting data points. So men are still more accepting than women. So our messages targeted towards women aren't being as effective as we'd hoped. We need to be reinforcing those. There's a confusion about the transmission. So a lot of people indicated water as a transmission point. So we needed to investigate that and have some messages around it's a mosquito-borne disease. That's how it's transmitted. People have concerns or questions about who's highest risk. So that's a good message point that we can talk about. Importantly, in this round of the survey, our social mobilization on the perceived dangers has evaporated. So we've managed to successfully communicate to people that these drugs are safe and they're not as concerned about the safety. And then lastly, people that participated more than once tend to be higher acceptability than people that participated less. This is just a good indication that the high acceptability keeps people coming back. So in this evidence to action pipeline, and I'm wrapping up really quickly, sorry. The data that we collected at baseline was used for social mobilization for the round 1, which was then incorporated into our end line data, which was then used for round 2, which is incorporated into the follow-up. And importantly, we're able to create this through line throughout all of our rounds of MDA and any future rounds of MDA to keep building back in this evidence that's supporting future rounds to ensure that they are the most effective and successful possible. And with that, I'd like to thank all of our project partners and thank you all for listening along.
Thank you, Charles. That was very clear and informative. So thank you. And I'll now jump to our third speaker, Musa. I'll just wait for the slide to switch. And yeah, so Musa is a PhD candidate in population health at the University of Ottawa, and he holds a medical degree from the University of Bamako in Mali, and a master's in science and disease control from the Institute of Tropical Medicine in Belgium. And he will share his research that focuses on reasons associated with never treatment during mass drug administrations to control and eliminate neglected tropical disease in developing countries, specifically in Mali. And so now I'll pass it to you, Musa.
Okay, thank you, Claudia, for this introduction. Do I have your control of my slide?
Yes, you should.
Okay. So I will not repeat you, Claudia, so I'll go straight to a presentation, which will which focus on understanding the barrier and facilitator related to never treatment during mass drug administration among mobile and migrant population in Mali. So just a brief introduction about Mali. For those who don't know, Mali is located in West Africa with a population of 22 million, and most of the population is at risk of NTD. So I'm happy James Charles has introduced what is mass drug administration. So since the implementation of this mass drug administration, Mali has made significant progress in eliminating several chemoprevention NTD. And so Mali has successfully eliminated trachoma in 2023. We are stepping down to LF certification. And for onco and cell transmitted element, we are on the stage of verification of the elimination. So only Somalis is still challenging, and most of the districts are still endemic for this parasite. The recent history of Mali revealed that multiple groups of population are moving because of conflicts and security, because of climate change, because of political instability and economic migration. Most of the people live under the uh, under the poverty, and this many circumstances has led to thousands of individuals being displaced. This graph shows here the displacement of internal population from around 2,000 in 2012 to 380 in 2022. So as a result, our population is made of an overlap of a multiple group of movement. At the same time, some of these movements are predictable, relating to seasonal change, while others are not. So the multiplicity of different population movement has implication for the implementation of MDA. The MDA work best in stable community and where people know each other, where people stay in one place for most of the year. And we know even for mobile, if we know with mobile population, even for routine healthcare can be difficult to deliver. So we can expect that some of this population will have never been treated during MDA. The slide is not going. Slide. Excuse me. So to address this question, we conducted a qualitative exploratory study to understand the barrier and facilitator related to nerve treatment during mass drug administration. Nerve treatment has been defined as a proportion of population who self-reported that they have never been treated for any MDA in the past. In order to help in their recollection, we showed to participant tablet to remind them about the campaign and to distinguish between NTD. Over the course of 2 months, we conducted 24 IDI and 12 focus group of discussion among our target group in 2 selected health districts, Tominia and Kalamankoro, where there are high number of IDP, economic migrant, nomad, and informal minor. So this slide outline here the reason contributing to non-treatment in the last MDA campaign. It emphasized important factors such as geographic, mobility, conflicts, and insecurity, economic constraints, and which significantly impact the accessibility to MDA. In Tominia, there are more IDP, which may explain why conflicts and insecurity emerge as a more important barrier to participation. While in Kalamankoro, there is more economic migration and gold miner, which explain why economic migrant and geographic mobility are of higher importance. So this slide highlights here critical factor that contributing to never treatment among mobile and migrant population. In Tomnia here, IDP are reluctant to seek treatment because they come from outside the region and can be discriminated by the local population. While in Kalamankoro, due to the high mobility, people are not reached by the regular communication channels and so remain in our about the campaign. So our participant also proposed some solution to address never treatment issues. So according to them, we need to ensure that our approach to MDA is flexible, understanding predictable movement and preparing for potential unpredictable population movement like an influx of IDP in a district. We need also to work with other programs like immunization program to learn from their best practice in reaching those individuals. Finally, we should also we should not treat every mobile group has the same. For example, a nomad is different from a young economic migrant, for example. So this study has shown that there are multiple barriers to participation which may result in never treatment. Mali has considerable success in NTD portfolio, but the increasing mobility of different population groups is concerning. So we need to rethink how MDA is carried out in view of this multiple mobile group. In terms of recommendation, so we need to implement flexible schedule to improve access of MDA among mobile and migrant population. We also need to tailor community engagement and need also more innovative research to understand the implementation and the impact of this mobile population according to their characteristics. And our funding in Mali here are more likely to be applicable to other regions where there have been significant movement due to insecurity, nomadism, economic migration. So I would like to thank our team here in Mali, Briere Research Institute, and the University of Ottawa, and also our collaborator at NIH. I would also like to thank all our donor partner. Thank you.
Thank you, Musa. Happy to see so much NTD representation at this event. And then just a reminder to all the participants, if you have any questions for Musa or for Charles or James, please put that in the chat. We are running exactly on time, so we will most likely have time to address any questions or comments that you have. So last but not least, we have Amarachi. And she is a recent graduate of the Masters of Public Health program at the University of Ottawa. She also holds a master's degree from the National University in Ukraine, and she will share her experience and research work in advancing stakeholder engagement and participation in global health, specifically in Tanzania. Off to you, Amarachi.
Hi, everyone. My name is Amarachi Asomar. Thank you, Claudia, for that introduction. So I'm a medical doctor and a public health professional. Like Claudia said, I just recently graduated from the MPH program here at the University of Ottawa. And my topic today is really centered on my global health experience on climate change and vector-borne diseases. And I'll take a more streamlined focus on advancing stakeholder participation in global health. So my background in global health started with my MPH practicum last year summer, where I traveled to Moshi, Tanzania for 6 weeks with my supervisor, Dr. Manisha Kulkarni. And our research was focused on identifying climate change adaptation strategies to reduce the risk of vector-borne diseases in sub-Saharan Africa, and specifically in Tanzania and Benin. So this research was funded by CIHR, which is the Canadian Institutes of Health Research, and resulted in a partnership between the University of Ottawa and the Kilimanjaro Christian Medical University College in Tanzania. So at the end of my practicum, we submitted a proposal for the New Frontiers in Research Fund Climate Change Initiative to implement projects in affected communities. And so this is a picture of me on the top floor of Kilimanjaro University College, just looking over like the magnificent view of Mount Kilimanjaro. This conceptual model really just establishes the links between climate change events and vector-borne diseases. And for our project, we focused on three main risks, which are the risk to human health, the risk to food security, and the risk to water security. This just shows that climate change indicators such as droughts, heavy rainfall, and increased temperatures are heavily impacting the distribution of vectors and vector-borne diseases. And therefore, our adaptation strategies in recent times have to evolve. From my experience in Tanzania, one thing that really stood out to me and served as a bedrock for our research was engaging with stakeholders from diverse backgrounds. We kickstarted our research plan with a 3-day research planning meeting, and we utilized the participatory action research methodology, which is really involving researchers, community groups, and other stakeholders in a shared process of learning by doing. So what do I mean by learning by doing? Just really involves mobilizing the knowledge of local people and prioritizing local needs. It also involves a mutual appreciation of each person's knowledge and skill set and focuses explicitly on the researcher's humility and modesty. Most importantly, every research done through the participatory action research has to be useful to the community. And to advance stakeholder participation in global health, the participatory action method is very crucial. So these are 5 key strategies and steps that I came up with just from my experience in Tanzania and just involving with stakeholder participations. And I'll be sharing more about these in the coming slides from my experience. And number 1 is to foster trust and long-term relationships. And second is communicate and sustain collaboration with participants. The third step is partnering with existing organizations that are local in the area and incorporating participatory research methodologies like the participatory action research that I talked about. And finally, and very importantly, sharing success stories and findings to help community empowerment and continuous engagement. Okay, so this picture was taken at a family's demonstration farm on the outskirts of Moshi with myself, 2 medical students from l'uOttawa, and a representative from Kiwakuki. Kiwakuki is a non-profit organization in Moshi that teaches farmers in these drought-prone regions climate-smart agricultural practices like drip irrigation and planting drought-resistant seeds. So this family had successfully implemented these strategies and had experienced a bountiful harvest in this season from applying these tips and concepts. It highlights the need to share success stories and foster trust to enhance the participation of farmers in the community for our research programs to advance. So here we went for a community outreach with members of Kiwakuki as well, in a nearby community, and we had conversations here with these women who are also participating in the Climate Smart Agriculture program to identify potential opportunities for partnership and highlighting challenges that they have been facing with the demonstration plot. And one of the challenges they highlighted was insufficient agricultural resources. And so this really conveys the importance of communication, collaboration, and partnership with existing organizations, like in this case, Kiwakuki. So I also visited the experimental huts in Misungwi, and it was really interesting to see how these experimental huts were used to trial mosquito bed nets and even test for insecticide resistance by different mosquito species like Anopheles Fanestas and Anopheles gabiensis. So it was a privilege and an eye-opening experience to appreciate the success stories and work behind participatory action research, collaboration, and partnerships with local organizations. I would have added the picture of the mosquitoes, but probably didn't want to scare anyone. The benefits of stakeholder engagement cannot be overemphasized. And throughout the research process, it's very crucial to note that stakeholder participation helps with inclusive decision-making among stakeholders. It helps with capacity building locally, but also internationally, health equity promotion among vulnerable population. And it also helps with sustainable research outcomes because they're really tailored to the local context. And lastly, co-creation and co-ownership of knowledge between participants. So I would like to acknowledge the efforts and support of IGO office for organizing this unforgettable trip to Tanzania, Insight Research Lab, led by my supervisor, Dr. Manisha Kokani, PAMVEC, our research partners in Moshi, and the staff at KCMU and research partners at the National Institute for Medical Research in Mwanza. Okay, so to end this is me on a safari trip to Tarangire National Park in Tanzania, and we say in Swahili, Asante sana. So if you have any questions, please reach out to me via my email, phone number, or LinkedIn. Thank you very much for your attention. Thank you.
Thank you, Amarachi, and thank you for all your pictures and sharing your experience. It looks like you had quite a nice time in Tanzania.
Thank you.
And so with that, that was our 4 speakers. So now we're open to any questions. And I see that we have one or a few now in the chat. And so I'll just go in chronological order. So first we have a question from Alex, and this question is for Musa. You're still online, Musa. They're thanking you for a brilliant presentation, and they want to know why political reasons and government failures to anticipate are not cited among the contributing factors of never treatment. So what's your view on that?
Thank you for this interesting question. Political and government failure should be cited, but due to the limited time we have, I just privilege some that the one I cited here, but of course, they are part of the reason. But I think that we should not take them like the most important one, because if we want to see all this globally, all the countries are not in the instability situation. So we should privilege those who are present in most of the country. And if you take Mali, the country is too big, and there are some parts where the country is stable, and the political instability is not really important in those parts.
Thank you, Musa. I think if there's any follow-up, please just put that in the chat, and I'll move on to the next question, which is for James. So this question is from Irvis, and they're thanking you as well for a great presentation and for your time. And they want to know what inspired your research in resiliency and well-being among community health workers in Ghana. And they want to know, did you notice any relationship between mental health and resiliency in some of the people you're working with?
Yeah, Elvis, thanks for the question. So the inspiration for my research in resilience and well-being in Ghana, it's actually maybe 3-pronged. First, I'll say my personal experiences. I'm from Ghana, and I grew up in rural Ghana where access to healthcare was really a challenge, not just for those who have, but most especially those who did not have. So, and within this setting, we hardly saw medical doctors. Most of the people were either nurses, and those we saw most often were community health workers. These were people who were selected from within the community to assist the nurses in kind of providing healthcare to the communities. And I do have really fond memories of most of these community health workers because of the way the approaches they used in providing healthcare was more humane. You were seen as their child, not like a patient. Even the methods, for instance, giving medications that were bitter to us, they would kind of trick us in a way that would take certain medications that were very vital for our health. So that's from the personal experience. And I did realize how important they were for the healthcare system. Now, I also worked as a researcher at the Oblongo Health Research Center, which actually piloted, that was after I now went to school and graduated, which piloted the community health worker program. And that really kind of like opened and magnified sort of like some of the challenges that these individuals experience, which were some of them included the fact that they usually made sacrifices. For instance, in the rainy season, everybody's on their farm and they have to leave their work on the farm. They're also like community members like all of us, leave their work, they will have to engage to go around and kind of like mobilize men for weigh-in and kids for weigh-in, or distribute medications as well. And they did not get any help on their farms. This can be very frustrating for a lot of them and challenging. They have to go through cross rivers and without sort of any means of transportation provided for them to reach these communities. So these are some of the things that culminated into my decision or my thoughts to sort of like look at how these individuals build resilience to continue with this work, and how does that also link to their well-being. Now, to your second question on whether there's a relationship between mental health and resilience, some of the people that I work with, yes, in the qualitative study, we did have themes of linkages between resilience and mental health. And that is actually what informed the second part of my study, which is to look at that relationship and how that relationship actually evolves over time. Now, my time variable here is the season, because the qualitative study, they did highlight a number of things, but most especially their challenges are usually within the rainy seasons and in the hot months. So I thought with my supervisor that why not explore that relationship over time, and we look at that time variable as the seasons and see how it varies and that linkage between resilience and mental health. Now, my second hypothesis was to look at that reciprocal relationship, because my assumption is that while resilience impacts well-being, someone with a stable mental health or well-being may show better signs of resilience than someone without. So that is also exploring that reciprocal relationship. I hope I have been able to answer your question, but that is about a short background to my research.
Thank you, James. Maybe can you briefly tell everyone what work you'll be doing in Ghana at the end of this month? Does that have to do with the mental health and resiliency component that you were discussing? Oh, you're on mute, James.
Sorry, I did not get that. I was reading the comment.
Oh, sorry. Can you maybe share with everyone what you'll be doing in Ghana at the end of the month?
Okay, so in Ghana, I'll be going in this April, to begin the cohort study, which will be looking at collecting data on the first time point, which is the dry season. The dry season usually runs from late December to the middle and end of May. So we will be collecting data for the first time point, and hopefully I will be going back into the field in August at the peak of the rainy season to collect data, the second time point, and then the transition season in between September and October to collect the third time point data.
Awesome. Thanks, James.
Yeah, I think we're running out of time, but I did have some considerations for people who are going into the field to especially in within the context of global health. So if anyone wants to know that, they can contact me.
Okay, and I see that we have one more question in the chat from Allison. She's thanking you all for great presentations, and she wants everyone to comment on how their position influenced their research. So for example, data collection, analysis, and interpretation. So I know we only have 4 minutes left, so maybe Charles, I'll target you to briefly touch on that.
Sure. So I think that I guess my sum answer to this question is that every time I go into the field, I have a completely different perspective on the data that I'm working with than before I was in the field. You know, you can have an idea of what you're working with, but without being on the ground and really experiencing the data process and like what the cultural context and health context is. It's really hard to have a clear understanding of what your data is telling you. I think the project in PNG, one of the pieces of it that I'm the most excited about to this day is that I was able to be in the process from the initial design of the data capture tool to the training of the enumerators to the data collection process to the data management process. And so through the whole data collection phase, I was able to check back and refer back at any given point and make sure that the data that was coming in was the data that we were planning to collect. And if it wasn't, then I was able to immediately check back in with the data team and figure out what had gone wrong. So the data sets that we were able to collect for that project are really phenomenally clean and don't have a lot of the problems that you usually have with data where you don't have that access and level of engagement with the teams. And so you often have little question marks all over your data of like, I don't know what happened here that caused this to not be what I'm expecting it to be, and I don't have any way of finding that. So being really embedded with the teams and with the local public health authority and everything is a phenomenal experience for being able to see your data with a whole new light.
Yeah, no, I agree. That's super important to look at the data through like a local lens, not a North American lens. And then it looks like we're at time. I'm sure we can all keep discussing important considerations for the next hour, but I'll be mindful of everyone's time. And I think that's where we'll end it. So thank you everyone for joining. Thank you to all of our speakers. And have a great day.
Thank you.
Thanks, everyone.
Thank you.